Let your wind blow over my garden. Let your wind blow over my garden. Away go north wind and come oh south. Let your wind blow over my garden. Smell the spices dancing in the air. Let your wind blow over my garden. Smell the spices dancing in the air. Let your wind blow over my garden.
Kapers moet ons probeer Afrikaans praat. Ek is van Natal af eintlik, maar ek probeer maar om die taal vlot te praat. My name's Steve Reed and I am at UCT and part of the organizing committee, and I'm one of the few people in the room who was at the first meeting of Rudasa. In 1996, 7, something like that. So, welcome this morning. We have quite an interesting day. When we were planning this conference, we thought we don't want people just to sit in a room the whole day for 2 or 3 days. So we planned this conference on the move. And we hope that by going out to the district hospitals and to the various NGOs in the area, we would break the usual conference style and get people more engaged with what's actually happening in this district. So we hope that the transport and the going and the coming gives people an idea of the geography of the area and what's happening in this district, because there's a lot that happens in and around Worcester and in the surrounding towns, including the activities of the Rural Clinical School and a number of very innovative and long-standing NGOs in the area. So I'm going to ask this morning the Deputy Dean of the University of Stellenbosch, Faculty of Health Sciences, who's here on behalf of the Dean, Professor Jimmy Volmick, to come and give us an introduction to the area, to the Rural Clinical School, and a welcome from the University of Stellenbosch. This is Dr. Therese Fish. So thank you, Therese, for welcoming us here.
Good morning, everybody. It's the first time that I'm going to give a speech in a church of this magnitude, and so I'm going to stand on the pulpit, if you don't mind. Because I'm a drama queen, so I thought I could see you better from up there. It also gives me the opportunity to read my notes more easily than down there. And I'm also now in my 50s, so I have to wear my spectacles to read my notes, so please excuse me that goes on and off. Welcome to the 18th Conference for Rural Health Professionals. I especially want to welcome you to our Worcester campus. So your theme for the conference, Building Resilience in Facing Rural Realities, is well positioned in the global agenda as we consider the post-2015 development agenda, as well as driving access to universal health care. So I'm sure you're disappointed that Professor Jimmy is not here this morning, but I will try to be your second best. And so I welcome you on behalf of the University of Stellenbosch, and especially our Dean, Jimmy Volmick. I feel a little bit under pressure after last night's keynote address, because I'm not blind, I don't do extreme sport, And I'm certainly not able to entertain you as well as Hein did last night. I had Steve read at my table. He was falling off his chair. I don't think, Steve, this morning that you're going to fall off your bench in the church. But I certainly just want to share some of our thoughts. But I went back last night thinking how inspired I was by the passion and the sharing that has come out through the conference. And we're so inundated with bad news stories in healthcare about systems that don't work. And just hearing the input was so inspiring, and I almost feel obliged to go back and tell my colleagues that as part of their performance management and their key performance areas, they have to attend the conference because we all need our annual dose of inspiration. And I think what you do at the conference certainly inspires us all. So many of you would have heard that in June this year we heard of the untimely death of our rector, Professor Russell Botman, who was the first black rector and vice chancellor of the University of Stellenbosch. Now, Stellenbosch is renowned as being one of the top 4 universities in South Africa, and we won't fight with UCT whether we are above them or below them, but we are in the top 4. But we're also notorious for another reason. And so we're notorious for the role that our institution played in the architecture of the system of separate development, the political system of apartheid or apartness, which undoubtedly has left the legacy of inequality within our society, more especially within the healthcare system. So at the time of his appointment in 2007, Professor Botman challenged us as a university community to ask the questions: how do we link our academic and research expertise and the excellence within our university to the development goals? And so how can we provide scientific solutions to tough societal challenges? And throughout his tenure as rector, he attempted against many internal and external resistances to address the issues of social injustice, discrimination and exclusion, both within the community of our university as well as in society at large. Now, let us not forget, we're in the 20th year of democracy. And 21 years ago, in 1993, 1 year before this democracy, our university had 1% of our student population that were black. Or let me say rather non-white. So 99% of the students at Stellenbosch in 1993 were white students. So we have made progress, but we still have a far way to go. And so we, like most universities globally, have to grapple with the role of universities in the 21st century. And in a society as unequal as ours, how do we ensure inclusivity, relevance, and responsiveness? And so the ministers arrive. Good morning, Minister. Welcome to our morning, and your seat is right in front here. So are you happy there? Okay. So in his inaugural speech in 2007, Professor Botman, as rector of the university, announced his vision for Stellenbosch University as a multicultural university with a pedagogy of hope for Africa. And he challenged us. He said, we want to be significantly different based on the past of our university, but we also want to be significantly better, as viewed against our commitment with regard to the future of the people of our country and our continent. And so he based his pedagogy of hope on the Millennium Development Goals, with the themes being eradication of poverty and related conditions, promotion of human dignity and health, promotion of democracy and human rights, peace and security, and the promotion of a sustainable environment and competitive industry. And so I don't need to tell delegates at this conference around some of the challenges that face rural populations in terms of health, in terms of some of the social issues that determine health and healthcare in this country. And those challenges are still enormous. So what did we do? In 2002, we launched our Ukwanda Center for Rural Health. And Ukwanda is a Xhosa word meaning translated to grow and develop within a community. And initially, our center was primarily a platform for undergraduate training. But there was a growing recognition of the benefits of recruiting from and training with rural and remote communities. And from the start, we knew that the exposure of our undergraduate students to rural settings would be for limited periods of time. And so the long-term intention was always to immerse students within such a rural setting. And so we wanted our graduates to understand the context in which healthy communities develop, and especially to recognize and be part of the issues around the social determinants of health. And so mostly in the first decade, our medical students did short rotations in rural areas, and over time our planning started to change as we recognized other immersion models in other countries. And it was during that time that with our major partner in this area, the Department of Health, we developed the discipline of family medicine and was recognized by our statutory professional council. And in the Western Cape, we developed a postgraduate training model for family medicine based on a hub and spoke model. And this model aligned with the service plans for the region of strengthening the district health services. And so in order to optimize innovation in rural training, the concept of our rural clinical school was developed. And it came to fruition because of the HOPE project that Professor Russell Botman had initiated. And so we received funding from the HOPE project itself, but we were also the university to come together at the time because two other major funding opportunities were made available. The Department of Health made the clinical training grant and an infrastructure grant available for universities. And so these various funding streams, and some faculty funding and private sector funding, we were able to open our rural clinical school in 2011 in this rural district of the Western Cape. So we developed a hub and spoke model with the regional hospital being in the hub and the district hospitals the spokes. And within this hub, we built our campus. And so we mustn't get ourselves confused. What you have across the road, that fantastic building, is not our rural clinical school. That's our Worcester campus. And our school is in fact a virtual school. It's got many, it's like a little like an amoeba. It has, and depending on how good our relationship with the provinces will even grow further, it will grow into the Northern Cape and the Eastern Cape. And so it's a virtual school, and it has to have many partners to make it successful. So we have 10 guiding principles that guide our initiatives, and I'm just going to read them for you. We want to recruit students from rural areas to encourage rural retention. We want to teach where the patients are to ensure relevant exposure to the burden of disease and practical experience. And we rely on our provincial departments of health to ensure that that happens. We don't want tertiary trained health professionals. We want to enable continuity with patients for better learning, continuity with their mentors for better guidance and supervision, continuity with the specific community for better service orientation and contextualization of health problems. We want to catalyze research in a rural context. We want to support multi-professional learning to foster teamwork, and I think we've been quite successful. You've seen some of the projects that our teams are presenting. We want to make use of IT to overcome geographic distances. We want to promote a community-orientated approach and a sense of responsibility for a defined community. And we want to enable longer exposure to the district health service so that the service learning becomes a win-win for both the health services and for the universities who train such graduates. And so through the visionary leadership of Professor Botman, our faculty has had the opportunity through the HOPE project to engage as a university in starting to address social justice. We've got many other HOPE projects within other faculties that also support some of the issues around social justice. And so what Steve told us we must have a tail end to your story. Wasn't it a very not a tail end? So I thought we better have some take-home messages. And so last night, Hein gave us 3 take-home messages. And I don't know, are the students here this morning? Can you remember the 3 take-home messages? I've forgotten the third one.
And then the second one is trust.
Come and help us. It's an open book exam. Appreciation, trust.
And the third one, oh, was giving time.
Yeah, so even if you give, we can all give a little bit of our time, especially because what he said. So these are some of my take-home messages. You have to have strategic partnerships in what we do. And so my challenge to us as universities and my challenge to the Department of Health, both nationally and provincially, is to say, let's make every health facility a place where we can deliver on the mandate of universal health care. But at the same time, let's make those facilities available so that we can develop our next cadre of health professionals. My second take-home message is grab opportunities. We grabbed the opportunity when the whole project came on board. We knew we had to. Our clinical training grant, many of the other universities use it very differently. We didn't just give it to departments and say, in the faculty and say, use what you would like to use it. We were strategic. We said, we want to expand and decentralize what we do. So grab opportunities. And you've got to network. You've got to know what's happening. So make sure that you extend your network. My third thing is take risks. So we took risks, and we told you last night about, and Hans, I don't know if Hans is here this morning, we sent students onto a longitudinal model. We had 8 students in our first year. We were, if I can say, damn scared that it would not work, because we were now taking students outside the comfort of the traditional training model. But we took the risk and we were successful. So take risks. My fourth take-home message is you've got to be passionate. Now I saw yesterday and I heard last night around passion. I heard around all the people that won awards last night. I think what they don't say about themselves is their passion. And so we have to be passionate. And so drive the passion, the students, you've got to be inspired by what happens here. And when you go back to the tertiary environment, in tertiary hospitals, don't let your spirit be dampened. We know students come in first year, they're passionate about being health professionals, and we kill them as universities. By the time they leave, they're so despondent about the system, they're all going to Canada. So let's try and stop that. And then my last message is, every year I have a motto, and so the mantra for the year. So my mantra for this year is, ask not what your country can do for you, but what you can do for your country. And so we were privileged to have Professor Botman as our rector for 7 years, and through his commitment, he enabled us to upscale our rural initiatives, and we salute him for that. However, we are equally privileged to be able to host this year's rural conference. And so to all of you who make healthcare for rural communities a reality, I salute you. Thank you.
Together.
that rendition of the national anthem, which for me was a first to hear it rendered in sign language. Thank you. And now it's my pleasure to introduce the Minister of Health for the Western Cape, Mr. Theuns Botha, who is no stranger to rural areas. He's a businessman and farmer himself, and I'm sure has his own stories of rural areas. But before you address us, Honourable Minister, I'd like you to know who is in this room. This is no ordinary conference. There's a strange group of people in this room who come out of the woodwork once a year from places like Nkanduli, near Coffee Bay, from places like Tonga, near Komatiput, from places like Pangwanas, near Cozy Bay, from places north of Polokwane, even from a place like Stegi in Swaziland, and from Lesotho. These are not your ordinary medical and other health practitioners. They're an extraordinary bunch of people, and it's my privilege to have known many of them for a number of years. And I look forward to this conference each year because it's such a source of inspiration for me and for many others. So I hope in your address that in a way you will be preaching to the converted. But this is really a special bunch of people from all over the country, and it's the one opportunity each year that we have to actually see each other, because distances are so vast and it's difficult to network. But we look forward to your address and to your welcome to this province, and particularly your perspective from the political point of view. Thank you.
I haven't paused on the steps, so please pray for me. Good morning to you all. Thank you very much for the invitation to be here. Professor Steve Reed, especially for the welcome that you've done, and the way you've done it. I'm very glad that you informed me who are all here, because I thought it's a Western Cape Congress. So thank you for broadening my spectrum and information about this Congress. The Deputy Dean of the Medical Medicine, Faculty for Medicine and Health Science, Professor Fish, thank you for your presence and the privilege to listen to your introduction here today. We've also have here the Chief Director, Chief Director for Rural Health Services, Dr. Annette Kraus. I think this is the first time in this capacity that you attend this Congress, most probably. So I want to recognize you. We have a special guest here from Brazil, Dr. Enrique Falceto y Barros. Is that close to what it should be? More or less. It's like saying Botha in English or in German, you know. It's all funny things might come from that. And then the performers from the National Institute for the Deaf for the opening of the ceremony with the very unique presentation of the national anthem. I think is very unique, and I think they deserve at least another round of applause from us. So to all the delegates and staff from my department and media and other people here present, I hope you will have a wonderful day and time here in Worcester. It cannot be too difficult. It's one of the most beautiful towns in our country and in our province, and enjoy it while you are here. I was inspired by the short message on that I listened from you in terms of the mantra and the values and the things that you shared here with us, Professor Fish. I think that there are enormous challenges in healthcare which are lying in front of us like a big, big mountain, an unsurmountable mountain. But when we take the time to really look at what we have in our environment and what we can do and how we can use or reutilize, then we find often many solutions which we were blind for a very long time. And I will try and deal with a few of them here today. In the Western Cape, we adopted in the year 2009, when we took control of this government, the objective, firstly in our government, to become the best run regional government in the world. And the emphasis is always on best run. And that is a very, very ambitious objective to strive towards. And when we had to develop our own strategic objectives in our individual departments, we in health decided that we're going to concentrate on a very single one issue. And that was then wellness. And wellness can be defined in many ways, and there are probably many definitions for wellness. And wellness is a wide or a regular used word for many things. But for us in wellness, it meant simply to have a population in the future that would be less ill and more healthy. Because we made a calculation and we came to the conclusion on proper analysis, not only to what we face in South Africa, but what is actually a reality worldwide. That healthcare is worldwide, public healthcare is worldwide in deep trouble. Everywhere, every country you go, the demand is much higher than the offer. There is never enough money for healthcare. In fact, if you would give the total budget of our provincial government to health, we would spend it all and ask for more. That is a reality. We also saw internationally how difficult it is for first world countries such as Britain, UK, Australia, the USA, many countries in Europe, to really have successful health models, public health models. We even witnessed that the countries such as the United States of America, which is supposed to be the superhero of everything, I also love about that, came to a standstill on a health ticket. The country actually ground to a standstill, to a locked situation, due to an indifference on healthcare. So healthcare is high on the agenda. And with us to become the best run regional government in the world, we decided on three main priorities. The one is we must have a vibrant, growing economy. If you do not have a vibrant, growing economy, you are farming backwards. So to enable us to have a vibrant, growing economy within a regional context where we do not control all the levers, you need to have two other very important things. You must have the best possible education system to ensure the best possible skills, and I don't have to tell you much about that. And then obviously, you need healthy people to do the work. And you need people's health to be in such state that it contributes to the economy and does not drain the economy. And that's why we then decided on wellness in our department. And when we looked closer at wellness, we realized that wellness really deals with every aspect of healthcare. Whether it is about the total budget allocated, the financial control and responsibilities, the number of staff, the state of facilities, the spread of facilities, the ratio between staff and patients, ratio between facilities and patients, the condition of your vehicles, the programs, the projects, everything is involved. Wellness is in everything. But there's also a huge component to wellness, which is actually a new component, which needs to be added to the conventional healthcare system, public healthcare system. And as far as we could determine, we were the first ever public Department of Health to introduce a few very unique wellness issues. We said it is our dream that in this province we would be able to create an opportunity. And opportunity is in our government a very important word. We believe in opportunities. Opportunity, whether it is to be safe, opportunity to have a job, opportunity to have the best possible health care, opportunity to be educated. We said we want to create an opportunity where every single individual in this province, private or public health patient, would have the access at least once a year to a proper health screening. And what we want to achieve with that is we want to give that person the opportunity to get the information on how to be as healthy as possible, to do early detection, and obviously prevention. And we realize that all over the world, public health care are for ill people. You use public health care only when you are ill or need medicine or need treatment. You never, and you can't, use public health care to prevent becoming ill or to have an opportunity to know what's going on in your body or an opportunity to get the most information to have the most healthiest or healthy life possible. So that whole component was an addition to what we said. Healthcare or wellness should be in a conventional public sector. And to fund and to do and to introduce that whole new component to healthcare, believe you me, was a miracle in 5 years. It was a miracle in government. Government is the slowest grinding machine that you've ever came across. There are 350 acts and laws preventing you from doing something. And you must try and find one that gives you the avenue to do it. You sit with 5,000 bureaucrats that tells you exactly why you are wrong. And only one or two that says, you know, I think maybe you have got something going there. And it is very difficult, especially in a very well-run department such as health, which has got an excellent history and reputation in management, in financial ability and control, and in outcomes in this country, the Western Cape Department of Health. So they had a lot to protect. And to bring on board this new animal was very, very, very difficult. But we managed to land the concept, to plant the little plant, the seed, and it's busy growing. Public or wellness in the Western Cape. And now, after 5 years, in a new term, we are adding budget to this. We've got programs, and we've got many initiatives on how we're doing that, and I will share with you a few of that. My office always prepared me very, very valuable notes, and then I deviate from that, and then I'm in trouble when I get off the pulpit. I always wanted to be here. In my family, you could become either a lawyer or a preacher. So now I'm a politician. So preaching from a pulpit. There are many things that we do in the healthcare sector in the Western Cape to improve rural healthcare specifically. We are very fortunate in the Western Cape that I believe we actually do not have deep rural areas. If you compare our rural to the rural of Mpumalanga or Northwest, or not Northwest, Limpopo and KwaZulu-Natal, I think there's no comparison. Our smallest little rural town or village has actually got proper services. There's a proper road to it. There are telephone lines, not always, there are poles, but not always lines. The infrastructure is there. The infrastructure, yeah, we also have those other elements here from the rest of the country. So, even our most rural area is very well developed. And therefore, I think that the Western Cape cannot really understand the full challenge of servicing a rural area. You know, when you speak about poverty in Africa, it's not measured on income, actually, it's measured on service, basic services. Is there a road to the village? And do they have a telephone in that village? And can they obtain a bag of fertilizer? So in many places in Africa, that is how you actually determine prosperity or poverty. And we're fortunate we do not have that. I always say to people that the ugliest little town in the Western Cape, but you should not tell them that. The ugliest town in the Western Cape is Rivier sonder end. And it is still a beautiful town. So I hope there's no one from the Rivier sonder end yet. Because the Meyer Crispin will kill me. Anyhow, so we can't really understand a rural area to the same extent as elsewhere in the country. And I think it's very important in healthcare to have the exposure also to that component. And therefore it's good to have those colleagues here today who, of some of them are coming from those rural areas, as we've heard. Because it has got its own challenges. What we did in the Western Cape is we decided that we want to create the opportunity to improve the ratio between facilities and patients, the ratio between staff and facilities. So we appointed 6,000 staff members more. We've increased the number of staff from 26,000 to 32,000, mainly on the service end. So that brought about the situation where we can today say in the Western Cape that we have a vacancy rate of less than 4%. We are very, very fortunate in that regard. And many of you who will qualify actually want to come and work for us. So welcome. We will be able to pay you. We have got a vacancy rate of less than 4%, while the country is suffering close to 40%. So that is something that I think is an enormous challenge. We have spent 1.7 billion rand on the improvement of infrastructure. We have completed more than 36, I think, facilities it is, during the previous past year, additional new facilities. New hospitals, new clinics, new ambulance stations, new forensic pathology stations, the upgrading, the rebuilding of many facilities. The most ever money was spent. We also were very fortunate to rebuild many rural hospitals, such as Worcester, which is for all practical purposes actually a new hospital. But we were also very fortunate to build 2 new hospitals, of which we are very, very proud. The one is Mitchell's Plain and the other one Kailicha, which are amongst the most modern in our country. So we were very fortunate to also improve that, the capital expenditure. Our physical infrastructure is very well in terms of EMS services. I think there is a display here today on EMS vehicles and some of the equipment that we have. I am always, every time, so impressed with what they have and what they can do. You feel safe in this province, knowing that. And that is the one component where we are all state patients. Whether you are a private patient or a public health patient, you might become a client of the emergency services. So it's good to know that we are in very good hands there with our average response times, the status and the condition of our fleet, the air support, the vehicle support that we have for so-called sitting patients, which is the so-called health net, in which we transport patients between facilities for the different appointments and requirements. So That is it. We have also introduced a new flagship program, which is something I want to reflect on briefly to you, and that is our whole wellness mobiles for schools. I don't know yet how many we will eventually need, but we need, I think, something like 21 or 22 of these within the next 5 years. We have just launched the first 5, 2 for the metro and 3 for the regional, rural areas. It is a big truck, ultra modern, fully fledged, as they say, state-of-the-art healthcare facility. Consultation room, dental chair, satellite connection, proper staff, everything. It is totally integrated into our system. And the first mobile wellness trucks that we have launched will screen all the grade R's and grade 1s throughout the whole province, and we will eventually add the mobile so that we do the screening at every interval that it is required, in medical terms, where and when it should happen at schools. And we believe that in wellness, in changing the condition, the illness and the health of our people in the province, you need to treat what is currently must currently be treated. You need to do what you need to do now, but the real investment is in the future. The real investment is in, from a pregnant mother right through childhood to adulthood, and therefore much of our attention and dedication is towards that. And therefore the school health mobile services is very, very important. So that has just been launched. It's a project which I think is very important. In the rural area, we also have the community health workers. We have health promoters. We have health posts. Health posts, I think, is perhaps something that many of you might not be aware of what we are doing in the rural areas. Is we have a health post on a farm or somewhere in a rural area, just a single room, which we use on a fixed schedule for farmers in that area or labourers in that area, and they know that every second Tuesday or whatever the service will be available there, and it's a more private place to do a proper assessment, and there are ablution facilities, and you can store equipment there and so on. So it is a facility that we try to take the healthcare as close as possible in the rural area to the community. Obviously, something which is an enormous challenge in our province in the rural area is the whole issue of migrant labourers. Migrants from everywhere, migrants from Lesotho, from Zimbabwe, from other countries in Africa, from other provinces within South Africa, and it's a big challenge. Language is a serious issue, and we're working on very interesting innovation in the e-health field, in bridging those problems with languages, but also to eventually be able to relocate or to send the information back to where that patient comes from, so that you eventually have a continuous service. So that is a huge challenge. And it's obvious, it's very often high pressure on small facilities in the rural areas, and we're still working on some solutions to achieve that. Our home-based carers, they do wonderful work in this province. They currently, we have just under 5,000 of them. They are responsible for close to 4 million home visits. So they are also a very important component, especially in the rural areas, taking information, taking medicine, bringing home-based care services. We've adopted the whole concept and principle of patient-centered approach. So when you deal with the numbers in healthcare, you deal with a budget of 17 billion, 600 facilities, 32,000 staff members, 5.3 million patients. When you deal with these numbers, it becomes a clinical environment, and you lose personal perspective. So we said, let's re-adopt a patient-centered approach. So when you use the facilities or the services of public health care, you must have a pleasant experience. You must reflect and say, this was good. Because it is often not good. It is often not good in terms of attitudes, in terms of waiting times, and things like that. And at the end of the day, those are human beings in front of us. And we want them to have a better experience. So that is a huge challenge. It requires behavioral modification within the organization, which we are doing professionally or with an outsourced company, but it also requires actually a major behavioral modification to patients on how they present to us and why they present to us. So these are complicated issues, difficult issues, and issues which are definitely not going to be solved overnight. But in adopting the patient-centered approach, our staff has changed the way in which they're dealing with patients. And we are really flooded, I must say, especially over the past 6 months, with compliments from ordinary people saying, you know what, I was scared to go to this facility. I didn't want to go to this facility. I just want to tell you it was a very pleasant experience. Thank you very much. And if you think that or realize that we are dealing with 83,000 patients a day, and one negative story has got a detrimental effect on the whole morale of the department because it's in the headlines, it is extremely valuable to get these compliments to keep you going. So we're very fortunate about that. But then an issue which Professor Fisher also mentioned, which I want to pick up here again also, is the whole matter of partnerships and the strategic partnerships. We realized very quickly that in healthcare, public healthcare, to achieve what we set out to achieve and want to achieve would certainly not be possible without successful strategic partnerships. And your university campus here is one of those partnerships. Your faculty came to see me. There was a deadlock in the development here. We unlocked that deadlock very quickly. We formed a partnership, and here your facility is, and that is only one of those. There are formal partnerships that we form with many private institutions. We have got very interesting partnerships going. We've got partnerships going in oncology services. We have partnerships with the delivery of medicine, the distribution of medicine. We have partnerships in the service platform of private pharmacies. I think we have more than 100 private pharmacies which are already now official public health care additional facilities. We are currently working very hard to establish the first successful partnership with GPs, also to expand our service so that our clients can use a local GP and the whole system is integrated, or the whole process is integrated in our system. So we are very keen and open and positive towards forming partnerships to solve the problems. Many of these partnerships are structured in a way that it has got advantage to the corporate sector, but some of them are simply a good deed as well. The last thing I want to mention, which is very important, that is a challenge we have in healthcare, I think, is that I think we should have a total rethink of the academic platform. From our perspective in the Western Cape, not from your perspective as in the academic field, but from our perspective from the provider of the platform, it is, for me, just makes sense to say that with all these new facilities we've got, with all these new technology that we have introduced into the system, and with the improved services to the far ends, and with the programs and the infrastructure of the department, it would just make sense to change the academic platform to incorporate more and a wider spread of business. The old or the conventional method of mainly tertiary institutions, such as the big hospitals, Fortescue and Tygerberg. I think we can add to that platform beautiful facilities such as Worcester Hospital, George Hospital, the new clinics we're building, the new forensic pathology centers we're building, ambulance stations, whatever it might be, the infrastructure to change the academic platform, to incorporate more. I also think, if I may say so, it might not be the most popular thing in this audience to say, that I think South Africa is ready to have its own private medical school. I do not understand why you can have private universities and private institutions of learning in every field except in healthcare. And I really think we should address this issue as well. It was meant that you should have passion, Profish. I want to add something. Without compassion, you can't make it successful in healthcare. You cannot be a successful health worker, private or public, if you do not have compassion. Compassion, mutual respect, equality, and those issues are the issues in the current South Africa, which would heal the wounds in many, many ways. Not only physical wounds, but mental wounds, and psychological wounds, and wounds of the vision and the wounds of the past, if we have compassion. Not what we do, but how we do it. And therefore I want to wish you well with everything you're going to discuss here today. I hope that you will have a bright future in this wonderful country, and we haven't got the money and the means to thank you for what you are already doing. Thank you very much.
Well, I think you'll agree with me that that address was totally appropriate to this audience. Thank you, Minister, for such a relevant talk and introduction to the Western Cape. And I think many people would feel jealous of the facilities and the approach of the Western Cape Department of Health coming from other areas. This really is an exemplary province. I've experienced that coming from KwaZulu-Natal, and things happen here in different ways. Particularly what you mentioned, the partnerships aspect. As an academic, it was very surprising to me to actually even sit in the same room with members of the Provincial Department of Health on a regular basis, on a weekly basis. And that's been fantastic from my perspective. But thank you for your speech. It really illuminated the whole context in which this conference is taking place. I'm going to move on with the program, with your permission, and I hope that you'll be able to stay to hear something of our colleagues' address from Brazil. And so it's my pleasure to introduce Dr. Enrique Barros from Rio Grande do Sul, the southern province of Brazil, who a couple of us visited recently when the conference of the World Organization of Family Doctors and General Practitioners took place in a small town called Gramado in southern Brazil. It was the rural chapter of what's called WONCA, the World Organization, and it was organized by a colleague of Dr. Barros, who was the chair of the committee, a certain Dr. Leonardo Targa. We originally invited Dr. Targa to come to this conference, but he was unable to, and at the last minute he pressed his colleague into service and requested Dr. Barros to take his place. So I'm very happy that he agreed and was able to come. Just to tell you behind the scenes, what happens is that Dr. Barros got to the airport at Porto Alegre with his ticket, only to be told that the ticket had not been issued. and he could not get on the aeroplane. Now, because of the time difference, it was the middle of the night here, and got this message to say that Dr. Barros has gone home again because he couldn't get on the flight. These last-minute conference kind of catastrophes tend to hit one in the middle of the night, literally. Fortunately, we were able to rectify the situation, get the ticket endorsed or whatever needed to happen, and he was able to get on the flight 24 hours later. So, for many reasons, but particularly because he brings a unique perspective on rural health, I'm particularly happy to have Dr. Barros here with us today. In his practice, which I hope he will describe in his talk, his practice is part of the family health system in Brazil, which, as many of you know, is one of the models that South Africa is trying to follow in terms of the primary healthcare re-engineering and the ward-based primary healthcare outreach teams. I don't think we've got it quite right yet, but let me give it to the horse from the horse's mouth. So I'd like to invite Dr. Barros to give us his address. Thank you.
Should I just speak? Okay, can you all hear me? So, goeiemorgen. Moeni. Bom dia. Good morning. Yeah, I think I'll just speak in English. So first of all, thank you very much for the address. I'm very humbled to be here with all these. I truly feel mavericks of healthcare, and I hope I can be of some value. And I think I might just help with the discussions about wellness and about how to go to the far side or to the deep rural. I might give you some ideas. And let me just grab this. So this is let me just see if it's working. Okay. So Professor Targa called me about more than 2 weeks, but not more than a month ago, and he told me, "Yeah, do you want to go to South Africa?" And I was like, "Sure, why not?" So here I am after that adventure, and it's a marvelous country, and I really love it here. And I'm planning to come back with my family, and probably bring more colleagues so we can do more exchange. But let me get down to business. It's 9:10 my watch. Till what time would we have? Okay. So what I would really enjoy doing, I don't know if that's possible, is to sort of give a talk instead of a great speech. I'm not very good with speeches, but I'm good with talking. So please interrupt me. It would be much, much nicer. I could just give you all the algorithms of what the government says it should be the model, but then you would miss my very unique experience of a family physician, rural doctor. And if there's anything of use from me being here is my unique experience. It's so it will be my perspective of a model.
So I'm going to interrupt already so that we set the tone. I asked Enrique to give us the behind-the-scenes view of the family health system. We've all seen it from a distance and it looks very nice on the surface. So the task for Enrique is to give us a behind-the-scenes perspective from the coalface.
Yes. So on the conference program, you have there that I would talk about the rural health models from Brazil. But when I was coming here, I thought, well, do we really have a rural health model? And so I changed a bit the topic and to, is there a Brazilian rural health model? And just to sort of get you started here. This is the town that I live in and I work in. It's actually 30,000 kilometers squared, so we don't have the whole town. It's mainly hills with forests. And this is a church right here, and I live right there, and my clinic is here. I have a picture of the clinic afterwards. So around here we would have around 1,000 people, and we have about 6,000 people scattered throughout this whole town. Yeah? But just to give you an idea of where I am, so this is Brazil, and we have about 8 million kilometers squared, so it's about 8 times the size of South Africa. We have about 200 million people living in Brazil, so it's about 4 times South Africa. Our Gini for the measure of inequality is considered high. I was actually surprised by that. It's probably changed a few years, mainly because of our social reengineering, Bolsa Familia, Hunger Zero, you might have heard of that. So now we have a high inequality. I believe South Africa is considered very high, but we're not that different. I've been around, I've been to some places in the Cape Town region, and I don't think it's that different from Brazil. Our human development index is considered high, but that actually surprised me also. It's in the last few years, so we're really getting the country going. And we have the 7th GDP. GDP, everybody knows. Okay, it's the money. We have a lot of money, but it goes places we don't know. Okay, I'm trying to move this. Okay, so this is actually our last issue of the Family Physician Primary Care magazine or periodical, and the cover is about rural health, because we're really struggling to define exactly what we want for rural health. And it was Professor Targa and Michael Duncan who wrote it. I'm very close to both of them. And it says here, Doctors for Rural Health in Remote Areas in Brazil, Situation and Perspectives. So they're really talking about rural health here. And so I will pretty much follow this script. So first of all, they talk about the model, which would be the family health team's strategy model. I'll explain it a bit more later on. And SUS, which is our unified health system. There's one key aspect about SUS which might interest you. SUS has been developing in the past 100 years, but mainly through a very, very interesting and very passionate health movement. And it helped to bring down dictatorship in '85. So a lot of the technologies that we have developed for SUS, for the unified health system, come from struggle for freedom. So in that sense, we're also similar, I believe, we're also similar to South Africa. Now, Targa and Duncan focused a lot in this, in the shortage of doctors for rural areas. We're bringing 14,000 foreigners to Brazil, just the last year or year and a half, 11,000 of which are Cubans. And it was something not very easy, very complex for the country. They're mostly coming, I mean, they're all coming under a 3-year contract, and they have no validation. We don't really know their training and their qualifications. So that's very problematic, and I might get into that if we have time. So this is a 2008 report from the World Health Organization, and it says primary health care now more than ever, which is pretty much addressing what the Minister of Health was saying, that we need wellness, and the way to do it is through primary health care. And there's very, very good scientific data and guidelines here, and there's a very good study about the Brazilian system, so I would very much encourage you to read this. You might get some very good lessons about health systems and where the money is more effective, more cost effective, and where you get more wellness and that sort of thing. This is our national health system, which I was talking about, the unified health system. And this would be the model for rural health. It says here, saúde is health and family. But as you can see, or perhaps as you cannot see, where's the rural here? I always have a difficult time looking for the rural here, but I guess it tells a bit about our model. It might have been more conceptualized in big cities. We have big cities like São Paulo, 20 million people, so they have a lot of voice, as opposed to most rural areas that pretty much go invisible, like in South Africa. So the health systems, we have been in Brazil struggling to move from hospital centrism, commercialization, and fragmentation, which tend to show worse outcomes in health, through primary health care reform or re-engineering, to health equity, universal access to people-centered care or person-centered care, and healthy community. This is also taken from the report I was telling you about. And so let's move on. So universal health coverage. That means everyone gets access to health. People-centered care. Care that is focused and organized around the health needs and expectations of people and communities rather than on diseases. And integrated service delivery. This is one thing that I learned, that you might be trying to move from a more fragmented service delivery in South Africa to a more integrated. Yeah, it's and I've come to appreciate and to understand better what integrated service delivery means. To me, it's very, very important, very, very important, so that we use our scarce resources in a very cost-effective and very focused into wellness. So the management and delivery of health services such that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, and palliative care services through the different levels and sites of care within the health system and according to their needs throughout the life course. Okay, so this is very important. Now, what I try to teach my students and what I try to do at my clinic is primary health care, and we try to follow Barbara Starfield's advice. I mean, not advice. She actually studied primary health care throughout the world and came up with a few attributes that would predict if we would have better wellness, better outcomes in health. And they are easy entrance door, integrality or integration, longitudinality, that means throughout time, coordination, so that when Dr. Enrique says one thing, the patient won't go to another place and the guy will say something completely different and the patient will be completely lost. So this is coordination, very key. Cultural competency, which the minister has already addressed very well. Focus on family and health. And here's again our logo for our model. Now, just to give you a brief history of our family medicine history. In the 70s, we had our first residencies established. In 86, we were recognized as a medical specialty. In 94, the government was convinced that this would be a good approach to have primary care being the direction for the wellness of the country. And in the beginning of the 21st century, it became so evident that that was the model to go for that it became a national strategy. It became recognized by very strategic and very legitimized and places in the government and in the Justice Department, that the family health became embedded in the governmental state culture. And more recently, because of the shortages of doctors, we've had some programs. This is more doctors. Provabi is also some sort of community service so that you would get students to go to rural areas, and lots and lots of Cubans. I don't mean it in a derogative way. It's just that it's a very complex issue, and we have to bring it up. So the family health strategy, this here again the logo. This is my clinic. Now remember the first picture, and this is close to the church, and this is me right there. This is 2 community health workers. This is our new nurse, and one of the problems with the strategy is that it keeps on changing the health workers, so that we lose many of the attributes that make primary health care very strong, and that is longitudinality and coordination. If you keep on changing the health workers, it disorganizes the healthcare, okay? And this is our administrative secretary, and this is a nurse assistant. And here's our logo again. Now, I want you to focus on this, okay? Because this might give you some more ideas. So I took a picture. So this is the whole area of the town. And this is supposed to be green. Can you see it? This is supposed to be yellow. It's divided right here. Now, the downtown, the which is very huge for me. We have about 1,000 people. So I feel kind of oppressed here. It's packed. But it's right here. I live right there and my clinic's right there. But we would have about 3,000 people scattered around here and the rest scattered around here. And we would have another outpatient clinic, health family outpatient clinic around here, and my clinic around here. Steve came up with a very good point, which is just in front of my clinic, we have the old hospital, which was shut down because it was very cost ineffective, but people are very used to it, so they still call it a hospital, but we have a different doctor come in every day, and I tend to call it the municipal or the town center for iatrogenics, which means physicians doing harm. And of course it's a joke. It's really meant to I'm just exaggerating, but it can get very confusing. So the models are competing. And so community health agents, again, I think this could be a good lesson for South Africa. And I just love to work with community health agents. So I don't know if you can see, there's a person here and a person there. This is the community health agent. She's measuring the blood pressure. And this is the other community health agent measuring the blood pressure. Oh, let me return here.
I have a question.
Yeah.
I have a question. It looks like you've counted the number of families and diabetics and hypertensives there. I just wanted to go through the list on the left and what that is about.
Pardon me?
I don't speak Spanish, so I just want to know what those
Oh yeah, I forgot. I was so impassioned about community health workers that I wanted to show them, but I have to come back to this. Sorry. So yeah, this is very important. Thank you for asking. So this means micro areas, and this my area will be divided into many micro areas. So we're territory based, and we divide it into micro areas, and each community health worker, I should have 5. So this is one community health worker, this is Nadia, this is Patricia, and this is the ones that I don't have, okay? So we really cover part of downtown and some of this area, but we missed the rest of my area. They're uncovered. And our model is very, we have to improvise a lot, and we have to be very passionate about it, because if not, we tend to want to go to Canada also. Yeah. So this is the number of families, and we have here 149. And here 146, I can't read it. Number of people per micro area, this is 413, this is 439. This is diabetes. How many people with diabetes we have in Nadia's micro area? This is 12. And in Patricia's area, we have 5. People with hypertension, 13. And people with hypertension in Patricia's area, 64. People bedridden, we have none in Nadia's area, 1 in Patricia's. This is children below 2 years. Sorry for the photo. Below 2 years, we have 7 in Nadia's area, 9 in Patricia's. And this is gestantes, pregnant. 1 in Nadia's and 3 in Patricia's. This is from last week, so it's very up to date. And the rest, I don't know. We don't have them. and if it was in South Africa, we would have TB down here, and then we would have HIV, because this is meant to be something to remind you of. And Professor Targa, which is much more organized than my, because I'm still implementing. His area is already very implemented. He has all the health workers, so if he was here, he'd give a better looking picture of our model. But this is what I live, and so he would have pin like a nail with a little bead. Drawing pin. Yeah, drawing pin. Yeah. So for each pregnant lady, you would have one pin, and so the mat would be covered, and you would know where each person from these numbers, each person where she is. So if you have an HIV person, you'd have a dot right there. It can be interesting to help you with public health. Now, community health agents, so they're from the community. They do an interface between professionals and community. They walk the territory. They help with communication. They do health promotion. And for us, it's a big thing that they started doing blood pressure, because our main cause of death now is from strokes, which the main factor, the risk factor, is high blood pressure. So we did something illegal, which is to teach them to measure blood pressure, and they're doing that now. It was, I say illegal because it would actually be considered illegal. The nurse council considers that only nurses can do it, and doctors. So we're pushing towards this. It's not that common throughout Brazil. I know that here you have a double burden of disease, so you have a very high burden of infectious diseases, as well as NCDs, non-communicable diseases, chronic diseases. So community health workers would be of extreme help, I believe. They are for me, and I learned so much from them. Every week we have about an hour to sit with the nurse assistant, and the community health workers. We just sit there and we talk. I ask them, okay, so how was your week? What kind of problems do you have? And we have this an hour-long discussion, and throughout time they become better and better at what they're doing, so that in the long run, they'll be very, very special, and they know every patient by heart, and they know which drugs they take by heart, and that's very important. But I have a weirdo colleague, which was the manager, that would break into our reunions, and it was a huge challenge just to convince him that yes, it was very important for the doctor to sit with the nurse and community health workers to listen to what was happening in the community, to get things going so that we can have wellness for the community. Because mostly they wouldn't understand it. They would just think it's not important. But it is. I think it's key, and I wouldn't be there. I wouldn't stand being there if it wasn't for this kind of opportunity to understand the bigger picture. I don't know, it reinvigorates me very much. I always look forward to this time with my community health workers. So this is a report from Britain where they were trying to implement something like community health workers. They seem to be interested in the Brazilian model also. This was published in 2014 by Johnson, They're actually doing this in the Wales, if I'm not mistaken. And this is what they're trying to get community health workers to do. So chronic disease management, triage, clinical care, social determinants, vertical disease programs like DOTS. So you could have the community health worker go to the house and the patient take the drugs in front of the community health worker. That would help a lot. Healthy pregnancy and child development. You could have the community health worker go house to house and see the children more than once a year. The person could go there. Sometimes if I have a person of risk, I can ask the community health worker to go there almost every day. Yeah. Healthy pregnancy, child development, screening, immunizations, breastfeeding support, health promotion, health protection, household data collection, health education groups, planning and performance, and community liaison. Yes?
I have to ask, what is the incidence of cerebral palsy in your area?
Cerebral palsy, you mean children?
With developmental delays, is there a high incidence of cerebral palsy children with developmental delays in your area?
Not in my area, no. No. Yeah. But I live in a state that would be it would be like, if I get it right, it would be like Cape, Western Cape to the rest of South Africa, and I live in a very special community where it's more equitable. So it's not just our program. Yeah. Now, this is home care. I actually go to the houses of the patients when they're too sick to come to my clinic. And this lady here, she was 80 something years old. And this is the son that would take care of her, and grandson. And this is me right here. And she was actually terminally ill, and we got together, the family, and they decided that they didn't want to take her to the hospital because it would make her sick. So this is a joke, actually. But I do get to see how people get sick in the hospital. That does happen. So the family decided to make her stay there, and this is actually oxygen. So she was in oxygen. I was giving her parenteral antibiotics, IV antibiotics, and it was very special, and they were very grateful. She passed with, I believe, the dignity that I would like to have when it's my turn. And okay, so this would be my last slide. Home visit, again, this is an 80-year-old man, and I took my students in a home visit. And this is the key person. She is a community health worker. This is at the university. And she identified this old man that was at very, very high risk to commit suicide. And she took us there, and we helped him a lot. And with very simple measures, we might change his life. And this is some numbers to show you. We have in 2010 we had 33,000 health teams, but many of them with doctors that would come and go, but it would cover, if you multiply 33,000 to 4,000, you would get a very high number, and that's the number we have now. Okay, so till 2010. We have more now. And this is to show the growth again, and how this is the area of Brazil, or the number of people that are covered by community health agents. So it was close to 50% and from 2001, and it's growing to 2010 to over 60%. And I have some more slides, but I don't think they're I'll have time to go through them. Let me just move on. This is to show how ambulatory care or primary care sensitive hospitalizations are falling as we start the primary health care program. And we don't have very up-to-date data because it takes a long time to analyze the data. This is the logo again, and I wish it was more like this, but we might have to come up with a new logo. And this is something that we have some specialists that will come and help our program. This is telehealth, very important, and we're making very fast advancements in that. And this is the program, More Doctors. And if I had more time, maybe we could talk about it, but I guess that would be about it. And so, just to, sorry because we didn't have time. This is the team of rural doctors, family physicians that we're getting together in Brazil to get things going for the rural area. And this is Croatia. We're going to have the next WONCA rural chapter in congregation conference in Croatia. So I guess I'm inviting you to go there. Thank you. I don't know, do we have time for questions?
We do, and that's why I suggested that we stop a little earlier, because I think it's in the exchange that you requested that the richness is. So I'm going to pass the mic around.
Enrique, muito obrigado. One of the big challenges I know that the system faced was around getting enough family doctors. South Africa, supposedly adopting the Brazilian system, has just decided to leave out family doctors completely in the process. But maybe if you could talk a little bit about how Brazil went about the process of recruiting, developing, training family doctors for the family health system.
Thank you very much for the question. And I've been learning a lot about the South African model, and we struggle very much with that issue, okay? And we haven't solved it at all, yeah? So that's why we're having so many Cuban doctors coming. I am a professor at the university, so I see, every day I see the huge challenge that is to convince graduating physicians to go work at rural areas and to go work at these rural outpatient clinics. And the real problem, I believe, is that doctors just don't want to go there because it's just people feel that you have to be either crazy or a maverick to do that, you know, because of the different sorts of difficulties. I don't know if that's the kind of answer you want, but I can't give you an easy answer, yeah? But it's very confusing. Just to give you an idea, the platform for I've been in my town for almost 5 years, and I'm hired by the local municipality, local mayor, yeah? and we had elections, and I was changing the way things are. And whenever you change the way things are, a lot of people don't like it. So the opposition platform was to fire me. And if I tell my students that, they'll say, "You're crazy, I'm not going there. I'm going to be in a big hospital and a soup specialist, because that's just easier." So you have to interest physicians if you are to have a physician rural primary care run model, you know. And we're just doing a terrible job in Brazil. We're actually scaring more with bringing all these foreigners. We're getting students more confused. We had made huge advances in the past 20 years. I actually got some students to get interested, but then the government does something completely out of the blue, and it just scares the students, you know.
Doesn't happen here.
Pardon?
I'm making a joke. Jenny?
Thank you very much for your presentation. I just want to ask about the training of your community workers. How long is the training, and is it standardized across Brazil, or do you have training in the different regions offered by, you could talk about a municipality or a city or a town, or do you have an NGO, someone else coming in to train your community workers?
Very good question. Zero training prior to coming to yeah. I just wanted to shock them a bit. Zero training. They come, they're really lay people, but what we have discovered is that they are effective. They just have to be oriented and told what to do, and we keep on training them. And we know that in a longitudinal perspective, they'll be even more effective. Yeah. So I wouldn't worry that much about the prior training, turning them into a profession. Now we've had them for a long time, maybe 20 years, and they've chopped down child mortality rates so that Brazil makes the headlines. It was really the community health workers that did that, I believe. From what I know, I'm not an expert in that field, but they would do like very simple things, like take water with salt and sugar. How do you call that? Yeah, oral rehydration. That's very effective.
I was wondering what accreditation process your foreign doctors undergo. I was there in April at some of your clinics, and the foreign doctors, from the day that they apply to the day that they arrive, it's a month and they're in the country. And in my country, it can take like 2 or 3 years before you're in. So it didn't seem like there's a council that they go through to accredit them or validate their qualifications. How does it work?
Zero accreditation. We don't. We don't control them. I mean, it's a funny thing. Brazil is highly complex, as is South Africa. Yeah, I'm struggling to understand South Africa, and if you go to Brazil, you probably get the same. It has some very good advantages to that, but it has its downfalls.
Do you carry the responsibility for emergency care in your area?
See, in my area, they would go to the Municipal Center for Iatrogenics, but I do some emergency. I would be prepared to do it, to stabilize the patient and take him to the appropriate level of care. So the model would take care of that.
If I can, sorry, I don't understand the Brazilian. Is it private and public as well? And then, so I mean, if you're talking about the hospital across the road that's giving all the trouble, and versus you're employed by the local authority, and then in terms of the carers, are they employed by the government, the local authority? With us, we pay an NGO, a non-governmental organisation, to manage our carers. And we sometimes, and they only work 4.5 hours a day, so I'd like to know how many hours your carers work. And the career path for them. For example, if you're saying, you're managing to keep these carers so that the absence of training, you're sort of training them in service. We find ours don't have a career path, if I can call it like that, and we have quite a high turnover. So as they get to know the communities and us, and then they move on somewhere else. I just wanted to know what your...
Yeah. We're trying to create a career path. We don't have that yet, and we have high turnover rates for your community health workers you're talking about, yeah? But it's supposedly to be all public, yeah? So when you talk about the unified health system, it's supposed to be public, and there are no fees, okay? Sometimes patients try to pay me, and I say, no, that's illegal, I can't take your money. Then they'll bring me honey or potatoes. Yeah. Across the road, the iatrogenics clinics, I'm going to stop calling them because it's really unfair. They're actually a private business of doctors that do Botox and genital plastic surgery, and they were hired to do this sort of cultural ritual of doctors attending patients, which I believe is very ineffective, and I'm very not passionate about it.
I would like to know your multidisciplinary team. Who is part of that team? Second question, part of the activities of the community care workers, you've listed them. I don't see anything related to rehabilitation. So who looks after the rehabilitation needs of the community?
Let me get that. So this is for community health workers, yeah? Community health workers. This is what you're talking about, yeah? Rehabilitation, we would have, let me see where the slide is. Sorry. Yeah. Would be here. So this would be deep into the community, and you would have, say, a physiotherapist go to my little clinic to do rehabilitation. The model is, it doesn't set a rule. It's very heterogeneous throughout the country. So actually at the old hospital that is not a hospital anymore, we have a physiotherapist, we have a phonoaudiologist, we have a psychologist, and they would all be under the specialty that would support, you see the hand here, that would support the family health team. Yes and no. It depends. They could go to the community. We have many problems within the factories. I have an epidemic of carpal syndrome, carpal tunnel syndrome. A lot of women can't wash their dishes anymore. So, and can't, it's a really huge epidemic. People just don't see it. I've been trying to get the physiotherapists to go into the factories. So that's very community work, I think. But it's very hard to do that. We haven't been able to do it yet.
I'm struck by the intimacy of the system. you've got a small department, one doctor in it, and community healthcare workers that are looking after 149 families. And I'm wondering about that kind of almost saturation of healthcare, which gives you such good outcomes. How do your community healthcare workers get around? Are they on foot? Are they cycling? Because in terms of where I work, we have community health workers which have huge numbers of people they need to look after and big distances, and they walk where they need to go, and it's not as functional. So I'm wondering how the functionality of your system works.
I think you have two questions in one. Yeah, about the saturation. It's too much health workers, really. Doctors, too many doctors, and it actually brings down. I've done some economy studies, and you actually have a curve for productivity. Yeah, it goes like this. But if you start adding more resources and you're over-resourced, it starts going down. So that's a classic economy. That's for anything you do. And we have that. I can clearly see it. That's why I joke about iatrogenics. So that's one answer. The other one is, how do community health workers go around? Yeah, they walk, they get rides, we have a car there, sitting there, but the mayor won't allow me to give the keys to the health workers. Yeah, it's a beautiful car.
Before the last question, the numbers are important. The figures in South Africa suffer one community health worker between 400 and 500 families. So we're probably looking at one community health worker to about 2,000 people on average. And so it's a matter of scale. And where Brazil is going to meet the Millennium Development Goals, we are not, because of that investment in primary health care that Brazil has made and that we have not made. So we have this model, but we haven't actually resourced it to the extent to which it can be effective. We have time for one last question in the back.
Okay. So you pointed out that strokes is one of your main causes of mortality. So I'm hearing, well, if they don't die, I'm hearing physio, OT, speech, audio, etc. But you also said that physiotherapy, I'm not sure about the speech and the OT, is very ad hoc, kind of organized within your system. So I just like to know from your point of view, how would you like to see rehab fit into your model, your team as it is at the moment? How do you think we could do it better?
Wow, that's a very important question. I'm going to answer just about my clinic, okay? I would like to work much closer to the physiotherapist, but we're changing the model, you see. The model would be the center for doctors and physiotherapists and specialties, more or less hospitalized. And we're changing that, bringing it to the community to get this more intimate. The word intimate is very appropriate, actually. It summarizes, thank you for that lesson. And I would like to have that kind of relationship. I can give you an example of what happened. I have a patient that do I have 1 minute? Okay. I have a patient that is a truck driver. He suffered an accident, and he was in the intensive care unit for 2 weeks, and he was intubated. He almost died. They had to drain out blood from his lungs and that sort of thing. And he was released from the hospital, and I saw he was getting better. But and so he went to the physiotherapist across the road, and to get some lung exercises. And what happened was that he started getting worse. And with Stridor, Strider, yeah. And what happened was that the physiotherapy freaked out, And he brought him to the iatrogenics doctor, who also freaked out. And they did an X-ray, and it showed a big pleural effusion. Yeah. So they rushed him to the hospital. They got him these all very high-tech, expensive tests done to him. And it was my shift. I went to the hospital and I saw him there, and they had no diagnosis. And I just looked at him and I knew his history. And I said, well, this guy has a problem, how do you call it, stenosis of the trachea. Yeah, I mean, you have to know the patient and stop doing all this nonsense. And the hospital doesn't have a bronchoscopy. We can't do that there. So it was completely useless and a waste of money, and they just scare the whole family. This family is disintegrating after that happened to this guy. So I'm very worried about the child. The mother is depressed and she's not taking good care of the child. So the child will probably have developmental problems. But instead of focusing on what has to be done, which is diagnosis, which will be best done by primary care, we spent all this money, thousands of dollars, in an under-resourced country, in one patient, when all I had to do was to talk to the physiotherapist. Like, hi, how do you do? Good. So this guy is bad. What do you think he has? I'd say, oh, that sounds like a stenosis of the trachea. So that's the intimate relationship we would have. And it would save us thousands. This is one very recent patient, very emblematic, if you will. And I can learn that much also from the physiotherapist. So, did I answer your question? Yeah.
You did more than answer our questions. Thank you, Enrique. Thank you for your explanation of the system, for getting under the surface, and for your passion, which comes through very evidently in your address and in your answers to the questions. Thank you very much.
Thank you.